Hello and welcome. My name is Marcus and I'm really happy to have you all here for an historic moment. This is the first UCARE LevelUp webinar. Now, I'm pretty sure that all of you know what UCARE is, the global network of Urticaria Centers of Reference and Excellence. Maybe some of you haven't heard about our fantastic LevelUp program. Starting now, this is the first webinar, but many other activities to educate physicians are already ongoing. We also have UCARE for You. This is the patient program. So we're doing podcasts, we're TikToking, we are doing journal clubs. Check it out. Go to the UCARE website. I'm really happy that you're here. And for today's first webinar, we will be talking about solar urticaria, which is a urticaria. Yes, it is, but one of the rare ones. So probably lots of things that you can learn and contribute today. I will share my screen so that you get an idea of what we want to do over the next 90 minutes. I have a stellar faculty with me today. It is really fantastic to have Leah and Karsten and Lesley. This is a Berlin-Manchester UCARE co-production, and then I have a very special guest for you, cameo appearance from London. I won't spoil the surprise, but maybe you can already see who will be here with us from the little windows where you can see all the faculty and our video feeds. Okay, this is what we want to do with you today. We will talk about the spectrum of solar induced diseases, and Leah will take on that part. Then Lesley will talk about solar urticaria specifically, also about the differential diagnosis, and that will tie us into erythropoetic protoporphyria, EPP, a rare disease, devastating disease that is easily confused with solar urticaria, or is it? That's the question that Karsten will address for us today. And then we have plenty of time to have Sheila come in and contribute to our roundtable discussion. We'll be done at 4:30, but please, let's make this very interactive. You have two ways to ask your questions. We prefer the Q&A box that you see on the bottom of your screen, but you can also just type in the chat and I will see the monitor and bring all the questions on board for the speakers and for us. So we have 26 countries, a truly global participantship. Happy to have you all here. Thank you for those of you who are in different time zones for making time and being here late in the night or early in the morning. And be ready for all of you to enjoy the next 90 minutes. Please do use the chat function. Hello, Maya. I see you all joining. Wonderful to have you. Reinhard is here from the UCARE office. We'll now hand it over to Leah. Leah, right here from Charité. Leah, the screens are yours. Give us a kind and brief introduction to yourself.
I jump right into the spectrum of the UV light-induced skin diseases, and I want to give you a quick overview about UV radiation and then what it does to the skin and the spectrum, of course, and in the end, the photodermatosis. So yeah, I first of all want to share with you a little bit about ultraviolet radiation. It's one of the most important environmental factors, and our sunlight that reaches our Earth surface contains around 5% of UV radiation, and the main part is UVA with 95%, 5% of UVB, and usually the UVC is completely absorbed by the ozone atmosphere, by our atmosphere. And this is also explaining a little bit how the absorption is and the penetration is in our skin. So the lower the wavelength of the UV light, the more energetic, but also the more absorption. So for example, UVB only penetrates until epidermis, and the UVA with longer wavelengths until 400 penetrates into the dermis. All this, of course, has an effect, cutaneous responses to the UV radiation. And it activates keratinocytes and other cells, for example, mast cells, and inflammatory mediators are released, interleukins, cytokines, and by that also the immunogenicity is increased. So we have immune suppression, but also more immune response. As every one of you knows, what is happening is DNA damage, causing the photocarcinogenesis. And there are also some responses like vitamin D production, the last step from 7-dehydrocholesterol to the active form, and the melanin synthesis, which is also helpful to protect us from UV light. Next, the UV light-induced skin diseases. So there you can already separate into two different groups, kind of. So the reaction to excessive cumulative UV radiation, everyone kind of is experiencing, and popular to everyone, sunburn and the skin cancer, different forms, and premature photoaging. And then there are also the abnormal reactions to UV radiation, and to this group, accounting the photodermatoses. And on the photodermatoses we are focusing today, and I want to give you a overview. And the photodermatoses we are focusing on today are mainly immune and metabolic, but there are genetic, which is also EPP, and photoaggravated like lupus, and also atopic dermatitis can be aggravated, and then of course drug induced dermatosis, for example furosemide. I wanted to start with the most common photodermatosis, polymorphic light eruption. About 20% in Central Europe can be affected, and mainly women are affected in their first 3 decades. And as the name already says, it's polymorphic. So there can be many different efflorescences, so pruritic papules, papular vesicles, plaques, and mainly it's one, but of course, it can vary. And what is experienced when it starts in spring, usually it gets better, and the patients are experiencing improvement. Another photodermatosis, a rare photodermatosis, not so common, is actinic prurigo. It mainly starts in childhood, and there is a HLA-DR4 polymorphism suspected, and also, of course, then a familial history can be reported. The lesions are also pruritic, papulous, nodules, crust, and then long term, because it's also more persistent, there can be lichenification and cheilitis. What is in this case also special, that it's also affecting unexposed areas, and So next one is the heterovacciniforme, also especially observed in childhood. And what is especially important in this photodermatosis, that to keep in mind that there are associations to EBV lymphoproliferative disease associations in very severe cases. The lesions are mainly vesicular, and which you can see on the picture, but also the healing in the pressed scar is what kind of gave the name due to its resemblance to vaccination scars. So I go right to the next one, the chronic actinic dermatitis. And this is mainly observed in older men. And what is important in this one, that there have been Sézary cells reported in severe cases. And here the lesions are eczematous, lichenification, and is also persistent. What it resembles also a bit, and what is coexisting in many cases, is the allergic contact dermatitis that should be kept in mind. And so this was kind of the spectrum of immune and idiopathic I wanted to share with you. Of course, solar urticaria, but this is is coming in the next presentation. And then I wanted to, which is also an important, photodermatosis, porphyria, cutanea tara. You can see here a patient picture, and here mainly middle-aged adults are affected, and is caused by a dysfunction of the hepatic urodoxychol decarboxylase. So there's an accumulation of porphyrines taking place. And so in acute phase, you can observe blistering, bullae, also crusts, and in the long term, there can be amelia observed and scarring, and of course, also hypo and hyperpigmentation. So this quick overview, and what I wanted also to share and keep in mind, that because the differential diagnosis is so important and can be difficult, is what is helping the differentiation by time of eruption and the resolution, what can help to find the right diagnosis, and of course then choose the treatment options that are vary a little bit, but I don't want to go into this today deeply. So so the time of eruption, minutes, and duration of resolution in solar urticaria and EPP. And then there are the photodermatoses that are taking a little bit longer to occur, but then also stay for a longer time, like PLE, chronic actinic dermatitis, and then also the lupus erythematosus, the part of the photoacquarated photodermatosis, and the PCT. So after this short overview of the spectrum of what we have in the photodermatosis, I am sharing this picture of a patient of mine with solar urticaria, not because I want to, I want to talk about solar urticaria, but another time. And I want to share with you that it's that it's so important to increase the awareness of those photo-induced skin diseases, so that physicians and patients get more educated about it, to find the right diagnosis, and by that find the right treatment. Also, especially in rarer forms, for example, solar urticaria, large studies on incidence, prevalence are lacking. What would help to get more insight, and also on the pathophysiology, so that we can provide a better treatment, and finally find complete cure for our patients. And that's how I wanted to end my talk today.
Super, thank you very much. Well done getting us started. Maybe you can unshare your screen, and that means that we can all see each other again. Are there questions? Are there questions for Leah? I heard your pitch for a better understanding for solar urticaria. Maybe you want to give us an update on where we stand with Soluce?
Yeah, sure. As some of you might know, we have a project getting started on solar urticaria. So solar urticaria comprehensive evaluation, which is a UCARE project globally. And we just recently finalized our steering committee, started on the project protocol, and will soon be having our first meetings on that and how to get it kind of started, really started.
Super. Hey, look, I'm looking at the all the participants. Fantastic to have so many of you with us today, and my guess is that we have at least 60 UCAREs on board here. Can I just ask you if you don't mind, everyone who's joining us today, and you are a UCARE, to just type your name into the chat box if you are interested in contributing patients to SOLUCE, the Solar Urticaria Comprehensive Evaluation Project, to start soon. This will give Leah and the steering committee a little bit of a better idea on how much feedback to count on. And of course, it's great, and we will hear more about solar urticaria. Great of you to show us that not everything that goes wrong when people have a sun-induced or sun-exacerbated skin disease is solar urticaria, but solar urticaria for sure is more common than we all think, I think. So let's bring out more info on solar urticaria. I see no questions for you at this point, but that of course can change. Leah, please stay online. I can see already wonderful. Frederico is on board. Yeah, keep it coming. I can see all of your names here if you're interested. Michael, super. Maya, of course. Luis, great. All right. Well, your support is greatly appreciated, and I see Leah smiling, so you've made her happy, just like you've made us happy, Leah, with getting us started. So that brings me to you. Lesley, are you there? There you are. Hi, Lesley. We're so happy to see you.
Good afternoon.
Excellent, wonderful. I understand, Lesley, you have prepared a little presentation for us, and we are ready for you if you're ready for us.
Well, good afternoon, and thank you very much indeed for inviting me to talk today for this very important endeavour to hopefully improve the understanding and awareness of solar urticaria. So just to introduce myself, I'm Professor of Dermatology and Photobiology at the University of Manchester, and I'm also a practicing consultant dermatologist at Salford Royal Hospital. And I'm lead for the PHOTODERMATOSES programme, which is a 5-year NIHR Manchester Biomedical Research Centre programme, where one of the photodermatoses I'm investigating mechanistically is solar urticaria, but I'm not talking about that today. And conflict of interest, I'm an advisor to, and I perform clinical trials in the photodermatoses, currently with Mitsubishi Pharma and Clinuvel Limited. So what is solar urticaria? Well, it's a rare chronic urticaria induced by components of solar radiation. And it's believed, although the pathomechanisms are unclear, as Leah was saying, it's believed that it's initiated through absorption of radiation by a chromophore or chromophore molecules that then transform to photoallergen or photoallergens. These react with IgE antibody, resulting in mast cell activation and the release of histamine and other vasoactive and chemotactic mediators. I can see my little figure has appeared now showing what we mean by non-ionizing radiation, which is what induces solar urticaria, and that comprises UVB, UVA, and visible radiation. Now, the reason why we think other pathways must be involved here is the variation we see amongst solar urticaria patients, both in the action spectrum, That's the wavelengths of radiation that induce the problem, and also in their responses to treatment, as well as some of the earlier investigations that have been performed in the disorder. So it's very important to define the case. What is the case definition of solar urticaria? And characteristically, this comprises erythema, wheals, burning and or itching, occurring on photoexposed sites rapidly, that's within minutes of sun exposure, and resolving within hours. The peak presentation is in young adults, early 30s, although we've certainly seen it present from infancy to the late 70s. It occurs in males and females, with females predominating. And we also have seen it in all skin types, right through from 1 to 6. The prevalence is estimated at 1 in 300,000 of the UK population, but that's an estimate based on what was seen at a photodermatology centre, so very dependent on what happens to be referred. So there haven't been any general population-based studies. Clinical presentation, I'm not an expert in other forms of urticaria, but from what I understand, solar urticaria is quite different in that the burning erythema and flare is often the patient's main complaint. And sometimes it's all we see clinically until we actually phototest them. So if you look at the two slides on the left, the top and bottom, you can see a very well demarcated erythema on the legs with a sharp cutoff where the clothing has been, and it's a flat erythema. In the next one along, you can see a lady who's got urticaria on her back, and this has happened through her clothing. Solar urticaria, in our experience, often happens through light clothing, and particularly on the upper body where you're projecting towards the sun. So you can see multiple wheals, but also a very inflamed erythematous background. The next patient, a young man, showing the exquisite photosensitivity. So he's got a strip of solar urticaria, a marked wheal and flare, and that's where his t-shirt came apart from his trousers. So that band of radiation there. And on the right, we've got a patient who's South Asian, skin reactive, skin type 5. And there, the erythema, as you might expect, is less easy to discern, but you can very clearly see the wheals. So in practice, what do we have to differentiate solar urticaria from? And we have to just differentiate it from other immune-based photodermatoses. For example, the rapid onset variety of PLE. So typically PLE does occur after a lag period following sun exposure, but we do see a number of people where it starts within 30 minutes. And we frequently get referred patients where the referring dermatologist has said, we think this is solar urticaria because of the speed, but actually it's polymorphic light eruption. So you can see on the left, there's typical PLE, vesicular, papular, fixed looking eruption. The next one along, the next hand, you have to look at fairly carefully, because if you look quickly, you might think, oh, that looks a bit like wheals and flares. But in fact, it is a papular rash. That hand belongs to the young man whose neck you can see, and there the polymorphic light eruption, even to be more troublesome, has got urticated areas. But the time course is not that of solar urticaria. Even if it starts fairly quickly, it doesn't disappear quickly. Systemic drug photosensitivity, which is quite a big problem. And what we find is it quite often presents with actually a rapid onset of a burning sensation, burning, prickling in the skin, sometimes with erythema starting very quickly, and later on perhaps edema. And there are over 3,000 drugs that are well-recognized culprits. Thiazides, quinine stay at the top, antibiotics, anti-epileptics. So the man at the top of the slide here was reacting to the quinine he was taking for leg cramps. And again, you can see erythema with a sharp cutoff. And there are a number of emerging culprits, proton pump inhibitors like omeprazole. We've actually seen quite flary type erythema reactions. The gentleman at the bottom was taking voriconazole for his aspergillosis. And photocontact dermatitis, contact dermatitis, yes, characteristically, these are delayed problems, but sometimes in the early phases, you can be a little caught out because they may just look like erythema with a bit of edema. Photoaggravated disorders also, particularly connective tissue disorders such as SLE. So at the bottom right, that upper back of a lady, you know, really quite, I would call them juicy plaques, erythematous plaques. But the time course isn't right for solar urticaria, but the appearance on photographs could be similar. And the legs next to her are her twin sister, in fact, who's also got SLE and has a number of rashes. And one of the things she gets is actually erythema fairly quickly on sun exposure. And looking at those legs, you would be hard pressed to differentiate them from the solar urticaria legs I showed you earlier. On the right, the lady there has photoaggravated atopic dermatitis, which again, typically it would look like AD, but in your photoexposed sites. But when it's developing in its acute form, you may just get a bit of redness and edema, and that's what she's showing on a holiday. And the photo below her shows her leg on holiday, but the leg to the right is again hers, and it shows it's developed over a week or so into typical eczema, dryness, scaling. The gentleman there with the hat, you might say, why is he in this talk? Where's his rash? Well, this is an important message. This gentleman's got a very severe type of light-induced eczema, but he photoprotects. He stays in, he doesn't go on holiday, he wears a hat. And this just goes to show that, you know, it's very behaviorally based. You have to be exposed to have the problem. Genetic photodermatoses, EPP, this can start very rapidly with a burning pain. Quite often nothing to see, but there might be erythema and, sorry, one of my slides didn't come down. There we are. So the hand you can see there at the top, thankfully, is very rarely seen, but patients often in childhood will have a severe episode, very painful, maybe as quite visible. And then the condition becomes really an avoidance disorder. They do not want that to happen again. So the hand you can see next to that is one of my patients, and he has got a bit of erythema and swelling. And that's his face below with the swollen lips too. He's got EPP. And next to him is somebody with EPP who's got some tiny little linear scars adjacent to her mouth that you can see if you look carefully in some EPP patients. Xeroderma pigmentosum can also present as a severe sunburn type, severe phototoxic reaction. So what do we do? These patients need a very detailed history. We set aside 45 minutes per patient to take the history. We use a very detailed proforma, and you have to ask very inquiring questions. How much sunlight does it take to bring it out? What's the lag period? How long does it last? Which seasons do you get it? Do you get it through window glass? What drugs are you on? What food do you eat? You know, lots of gin and tonic will give you quinine, lots of parsnips will give you sorolins, and occasionally you come across people who are having lots of those things, and it does make a difference. Examination. So if they've got the rash on them, is it photo-distributed? You know, are there scars? Are there marks? Urticarial vasculitis, for example, you know, you would have a violaceous marking left behind. Patient photographs have totally transformed, because I can remember the days before mobile phones were regularly used, and it's really transformed and made our job so much easier because patients can bring the photographs to you. Lab tests routinely include porphyrin, urine and blood scan, and a connective tissue disease screen, amongst others when indicated. And then photoprovocation. So we use two broadband sources, broadband UVA, you can see, and solar simulator. Solar simulator, that's a bit of a misnomer because what it means is solar simulated ultraviolet radiation. There's very rarely any visible in people's solar simulator emitted by, but the spectrum of UVR is much more like sunlight. So 5% UVB, 95% UVA, but also much more in the longer wavelength UVA. So whereas both sources can be very successful in solar urticaria, solar simulator is more successful in our hands than broadband UVA that's basically Hoover-type tubes. Action spectrum and thresholds. We test people to individual wavelengths, plus or minus a bandwidth throughout UVB, short wavelength UVA, longer wavelength UVA, and visible radiation. And we do a dose response from left to right, so we can determine the thresholds. Normally with monochromator testing, you're looking at MEDs, you're looking at the 24-hour erythema response. But of course, with solar urticaria, it's the immediate responses that are really important. And you can see some lovely slides there. It can be even lovelier than the clinical photographs because you're giving that targeted little 6mm circle of radiation. Normally we will group all the tests as in the photograph at the bottom, but when we're doing trials, we space them out so we can actually measure the area of the flare as well as the wheel. So we can look at wheel and flare thresholds separately. So we've reported on action spectrum in the largest single center series of solar urticaria, 145 patients, and that's from a couple of years ago. So we've regularly got a lot of, not a lot, but probably about 10 or 12 patients a year coming through. And provocation in SU, is it always positive? Well, we find if we use both narrowband, that's the monochromator, and broadband testing with a solar simulator, we can provoke it in about 75%. So about 25% are difficult to provoke in the lab. Sometimes if that happens, we'll put them outside in sunlight, and that may do the trick. Broadband alone, positive in 2/3, monochromator alone, positive in less than that. So if you've got both sources, use both. What's the action spectrum? In those provoked by the monochromator, we found that the peak wavelengths are the longer wavelength UVA, 370 nm, and the start of visible radiation at 400. So the top graph is in our own unit. The bottom graph, we've looked at other centres that have reported on monochromator testing in smaller numbers of people, and that very much agrees. And that was very helpful too, because one of the centres had done some of the wavelengths that we hadn't looked at between 400 and 500. And again, 400 nanometers came out tops. And this is a problem for patients because this explains why their condition tends to be all year round, UVA visible, and also why regular sunscreens aren't much use. So we've used these quantitative systems to test out systemic agents. And I'll need to speed it up a little bit, but so this one was using an alpha melanocyte stimulating hormone analog, afamelanotide, and we found that a single implant increased the mean MUD, increased the wheel area, and increased the flare area. So it protected against both components for the 60 days of the trial. And this is omalizumab in solar urticaria, and just 2 patients here. The upper one, you can see he had a broad spectrum solar urticaria throughout all the wavelengths apart from 300 and 600. And on omalizumab, his thresholds, well, it's actually, we weren't able to provoke solar urticaria at all, except at a very high dose with the 400 nm. When it was stopped, it drops down again. The lady below showed sensitivity to 2 wavelengths, and again she showed a good response with an increase in thresholds, which clinically made quite a difference to her actually. If you can spend 30 minutes in sunlight rather than 15, it does make a difference to your life. So the arms there are the upper patient, and you can see a really big wheal and flare response, and on treatment, nothing at all to the same dose. And our literature review at the time, we looked at responses to SU on omalizumab. They were assessed variously, not all quantitatively, but in 41 cases, 28 were said to be completely responding, 6 partially, and 7 not. So the majority doing very well, but with some heterogeneity. And then qualitatively, we've also looked at clinical scoring for itch and flare and quality of life. And you can see that the itch and flare score disappears to 0 on the omalizumab in this patient, and the quality of life score improves greatly on treatment. We also look at quality of life over the past year as well as past week, because if you've not happened to have been outdoors in that week, then you're not going to have your solar urticaria. So it's more complex doing clinical trials in photosensitivity conditions than, for example, psoriasis, where you've got a fixed rash. It all depends on the stimulus and patient behavior. So to conclude, solar urticaria has a major impact on lives. I didn't flag up there, but in our patients, 70% have a very large impact on quality of life. 70% with a DLQI over 10, and with the specific urticaria scores agreeing. So this poor man here, this is how he routinely dressed: gloves, a hat with a cap over his face, glasses, and a balaclava. I mean, he must have scared people going out like that. He used to jump from his car into his shop, and like, you know, I've had a number of patients with SU who were incredibly distressed, the most distressed people I think I know. On one of the treatments, he is absolutely fabulous. He is now surfing, not on the internet, but on the sea, actually surfing and doing high altitude mountain walking with a lot of that clothing removed. So a number of patients have said to me that they've had a life-changing, life-transforming or miraculous treatment, and I'm not putting words in their mouths. So very effective treatments are emerging, which suit some patients. So it's absolutely vital to identify and correctly diagnose solar urticaria so we can specifically manage it. Thank you.
Thank you, Lesley. I think you have, in a major way, contributed to this, educating all of us about solar urticaria and how to diagnose. And we have some questions coming in. Anna has the first question. She thanks you for your excellent talk. Let me echo that. And probably on behalf of all of the network, is interested in what do we as, let's say, not photobiologists and dermatologists in the strict sense, what do we have to do good provocation testing? Is it enough to do UVA, UVB visible light to diagnose solar urticaria and get a differential diagnosis? What's your recommendation?
Yes, I mean, I've been meaning to send you our sort of the details on the lamps we use. And part of the problem is you can't buy suitable things off the shelf. They are not designed for that. They're really designed for in vitro use, you know, in laboratories. So everything that we use has been adapted locally. Okay. We're very happy to share our formula. But speaking to our physicists here, you need to have somebody in-house who will actually adapt equipment for you. And you know, a UV physicist is incredibly valuable. But if you have a very, very good, you know, more sort of specialist medical engineer who's willing to learn, so you need somebody smart. So because these things are developed in-house and probably don't, they probably don't have the license to be transported elsewhere, but we're willing to help as much as possible. I think solar simulated radiation is very, very helpful. You know, if you were going to do a trial across various centers, you would try to match the lamp. You might even need ideally to have a physicist going around testing them. So our equipment, it all traces back to our central national physics laboratory, so that we can compare doses.
Well,
one of the problems that I've noticed too is when it comes to broadband UVA, like a PUVA lamp, they're the same everywhere, but UVB lamps are incredibly different. So you could not say test with a dose of 20 millijoules per centimeter squared, because it'll give an entirely different challenge if it's TL01 narrowband, or if it's TL12 or UV6. So you're not comparing like with like. We get around that a bit by talking about erythemally weighted doses, and then you can use the same dose if it's erythem, but not if you're looking at the total dose.
Yeah. Makes sense. We'll take you up on your offer, Lesley, for sure, because we're a global network. We're in more than 40 countries. We need a global standard for the testing. We most of us strongly feel that disease activity in all chronic inducible urticarias is measured very well by looking at the threshold. So that's another thing that we would love to establish across all the UCAREs and help others to do this as well. Thank you very much for the offer. Atsushi also from Japan says, that he picks on the same problem that you already talked about. And there's another question on how do you test for visible light? I know that some centers just have an old slide projector that we sit people in front of. What do we do? How do we do it best?
Well, in the UK, what we would say is, please get a monochromator, because then you can test all the wavelengths. If you're a research center, I would say have a monochromator system, because then you can go out to 600 nanometers, well into the visible. So slide projectors, that's not something, we don't use a broadband visible source, we use the narrowband visible source.
Okay. Very good, thank you. Any questions? Well, we have plenty of time later on. I suggest, Lesley, thank you very much again. Karsten, maybe you take it away for EPP, and then we can all, without slides, be on screen and address all the other questions that are here. I still have 2 more in the chat function, so please keep them coming either in the Q&A or in the chat, and we will get to all of your questions after Karsten's presentation of EPP, an overview on diagnosis and therapy.
Thank you very much, Marcus. Yeah, it's a big pleasure for me to talk about erythropoetic protoporphyria, EPP, because this is really a very interesting disorder. It makes a lot of fun to care for these patients. These are very nice patients, and we have an efficient or effective treatment that we can offer. So this is why I'm really glad to have this opportunity. But let's start with a classical clinical EPP case. This is an 80-year-old woman that we are treating in our center, and she started to have first symptoms at age 1. They were in summer holidays in Poland. She was crawling in the garden, and then she cried the whole night. Next day, she had an erythema on the back of her hands, and the family just didn't know what it is. The family thought it might be an allergy against food, whatever. They just didn't know. But the next year, when they were again in summer holidays in Lanzarote, the same happened again. She was in the sun and started to cry minutes after direct sun exposure. So after that, it was somehow clear to the family that there was some problem with the light, but there was no diagnosis until the age of 10. And it was finally made by a dermatologist, very normal one, no scientist, who remembered EPP from textbooks, never saw a patient before, but just remembered that. And this was great for the patient and the family. She then had a name for what she had and needed to really strongly avoid sunlight. This was really very much as a child and as a teenager impaired her quality of life. She has a classical thing EPP patients has, like and we call that prodromal symptoms. So after 5 minutes, she already starts having slight burning and stinging on her skin, and then she knows, okay, I have to immediately seek shade. And when she does it, she can avoid a stronger reaction. So this is like a warning signal many patients have. And if you ask these patients, for example, pupils, and ask them for the way to school, they will be able to exactly tell you where on the way to the school is shade. So they really jump from shade to shade. Then when she got older, they were on a class trip to England, and it was a sunny day, and she was forced to join the group, and really had a strong light exposure there, and had a really traumatic episode. You can see the picture of her after that. This was also published in a newspaper in Germany. And there she really got a strong reaction with redness, even blisters and crusts later on. This is not what usually happens, but this is one of these traumatic episodes already Lesley told you about. So this is something the patients have 1, 2, or 3 times in their lifetime, never again, because they do everything to not having to experience this again. And then until age of 18, she had no effective treatment because there was just nothing. She only tried to avoid light as good as possible. So this is a typical EPP case, but the question is, what happens in EPP? EPP is a disorder of the heme biosynthesis pathway. And you may remember it. The last step is where the ferrochelatase FAC inserts iron in the protoporphyrin 9, the PP9, and finalizes the heme biosynthesis. Well, in EPP, there is a partial deficiency of the ferrochelatase, and this leads to an accumulation of PP9. And this is causing the EPP symptoms. I will show you in a minute why this happens. There is another disorder, but basically with the same symptoms, which is called X-linked protoporphyria. And this is a gain of function mutation in the ALAS, so in the initial step of the heme pathway. And this also leads to an accumulation of PP9. And this is the reason for this is that the ferrochelatase is the dose limiting step. It's the bottleneck of the system, basically the same symptoms. So why is the ferrochelatase deficient? What happens there? So let's look at the genetics. We have 3 options. We can have a normal FAC allele. We can have a loss of function FAC allele, which is quite rare. And there is also a low expression FAC variant, which is the case in 10% of Caucasians. So now there are different options. One option is that there is a loss of function allele and a normal allele. This would not be sufficient to cause EPP. But if there is a loss of function allele that comes together with a low expression allele, then there will be an EPP. The FAC function will go down to less than 30%, and this is the critical threshold. Up from that, the PP9 accumulates and the patients develop EPP in symptoms. The same, of course, could occur if there are 2 loss of function alleles in the same patients. It's rare, same EPP symptoms. And what quite happens more often is that there are 2 low expression alleles come together. This usually not leads to EPP symptoms. These patients usually have no EPPs, although there are some reports in the literature about slight symptoms in few patients. EPP is not as rare as we think. There was a study in the UK Biobank actually, where they found a prevalence of around 1 to 50,000. This is 2 to 3 times more often than we thought. So EPP is often overlooked, and this is also nicely why we can do this presentation today. But what is the problem of PP9 accumulation in EPP? And I will try to explain this shortly. So the problem is that PP9 is a photodynamic substance. So PP9 can absorb light, enters an excited energy state, and then again releases this energy, which leads to the formation of reactive oxygen species. In EPP, this should be a blood vessel, what you see here with erythrocytes in it. In EPP, the PP9 is strongly abundant, and it is lipophile, and it's in the membranes of the endothelium and of the also of the red blood cells. And now what happens is when the light shines on this PP9, again, these are activated and the reactive oxygen species are released. And then we have a strong inflammation there with vasodilatation, extravasation, activation of nerves, release of pro-inflammatory mediators. And this is really, really painful reaction. And maybe some of you treat patients with photodynamic therapy. There we use the PP9 to destroy epithelial cells. So there it's just in the epithelium and not in the deeper tissues. And already this treatment, photodynamic therapy, is so painful. And you can imagine what this pain is in EPP patients. What is important to understand is that the spectrum of light that is causing this PP9 activation is in the visible spectrum. So primarily the SORAD band, slightly above 400 nanometers. This is the important wavelengths. In other words, UV protection does not help in these patients. But not only the skin is affected in EPP, many patients have cholelithiasis, so the protoporphyrin crystallizes to gallstones. This is one problem, quite common. But what is more important is that in around 1 to 5% of patients, there is a cholestatic liver failure that occurs sometime in their lifetime that then requires liver transplantation. And this is due to an accumulation of the PP9 in the liver. And what is typical preceding this cholestatic liver failure is that the PP9 levels strongly increase before, and then at the end stage liver disease, there's just nothing we can do apart from liver transplantation. In addition, many patients have a slight anemia. We are not know for sure why this happens. It's not a classical iron deficiency. And of course, due to the sunlight exposure, the patients virtually all have a vitamin D deficiency and are at a risk of developing osteoporosis or even osteoporosis or osteopenia. So how do we diagnose EPP? There are two major columns. First of all, there are major hints from patient history. And secondly, there is a very easy laboratory diagnosis. The major hints from history, I already showed you a little bit in this clinical case. There is a manifestation already in infancy or early childhood. The patients develop these phototoxic symptoms very early after sunlight exposure, usually within minutes. They have this warning sign, this prodromal signs. And this pain is really massive. It is not responsive to analgetics. And it's there for a long time. The recovery from stronger symptoms takes up to 1 week. What is also typical is this: if patients were in the sun and had prodromal symptoms or even slight problems already with pain in the skin, they are more sensitive the next days. Patients can develop erythema and edema. But what is often textbooks that they have vesicles or bullous lesions or scarring and so on. This is really rarely seen. And this is also why patients are often not taken for serious, and when they come to physicians, and also their environment often does not take them for serious, which causes an additional burden for the patients. So if we have a clear history, of course, we suspect EPP, and then the only thing we need to do is determine the erythrocyte protoporphyrin levels. This is an easy blood test, really easy to do, and if it's more than 3 times the upper limit of normal, the EPP diagnosis is virtually there. Most patients have strongly elevated levels, like 50 times the upper limit of normal is not unusual. And if this is the case, we of course confirm the diagnosis by genetic testing for the FAC and the others to see if it's EPP or X-linked protoporphyria. So the diagnosis is easy, and if it's made, we do something in addition to that. Usually every year, we look for a blood count, ferritin, transferrin, we look at the vitamin D, we look at the hepatic function in the lab, and also with ultrasound, ideally also with the FibroScan, to really make sure that these patients are not going into a liver problem during the course of EPP. It's rare, 1 to 5% only have a severe liver involvement, but it is there, and we have to take this into account when caring for these patients. So now the last part of my presentation, the management of EPP. There we have basically 3 things. We have the light protection, we have the pharmacotherapy of the EPP, and we have the treatment of complications. Let's start with the light protection. As you know, there are several sunscreens on the market. The problem is that the chemical filters in all these products work very nicely in the UVB and the UVA, less good in UVA already, but they do not work above 400 nanometers. So forget about chemical filters. They don't work in EPP. What we can do is provide chemical filter products with zinc oxide or titanium dioxide. They help a little bit, but of course they are whitish, and this is usually cosmetically not acceptable for the patients, causing an additional stigmatization often, and this often is also not very effective. And of course, what really helps is a textile light protection, but this is, as you can see on the picture, no real solution for the patients. This is also strongly stigmatizing when they need to walk around like this in the summertime. What we can do, fortunately, in the meantime, is we can treat the EPP with a licensed drug, afamelanotide. Afamelanotide is the only licensed option that is efficient in EPP, and afamelanotide is an alpha MSH analog. It binds to the MC1 receptor, which is then influencing the eumelanin genesis, and so this is stronger, and then this leads basically to the natural light protection mechanism for these patients. In normal life, UV light would cause keratinocytes to release alpha MSH that binds to the melanocortin 1 receptor. In this case, this is mimicked by the afamelanotide, and the whole light protection system is increased by afamelanotide. The drug is given as an implant, a subcutaneous implant, every 8 weeks, up to 4 times per year, but it's licensed only for adults, and this is of course a big problem. And it was licensed under exceptional circumstances, which means that the licensing agencies were not fully convinced about the efficacy of the drug, and so the drug is only available in dedicated centers. In Germany, it's only 4 centers where the drug can be applied, and we are one of these centers. How about the efficacy? In the pivotal phase 3 studies, afamelanotide was able to increase the hours in direct sunlight between 10 a.m. and 4 p.m. without pain. by around 55 to 60 hours in a 6-month study period as compared to placebo. It also reduced the number of phototoxic reactions in these patients, the mean duration of these reactions, and the mean severity of these reactions. However, this was not completely convincing the licensing agencies, but we have now more data from the real-life treatment, and I can tell you that in the real-life treatment, it is a highly effective drug. Here you can see a series from the US, where you can see on the left side in red, the time to prodromal symptoms before treatment, and on the right, the time to prodromes after treatment. And this is really impressive. The prolongation until in direct sunlight, the patients have until they develop first symptoms is really is a bit different, but it's really strongly in many patients. Some patients can tolerate sunlight for several hours during this treatment. In addition, we have data from a post-authorization safety study that accompanies the afamelanide treatment. And here from June 2016 to June 2018, we have data on more than 200 patients. And what was found is that only 4 patients stopped treatment. So the drug survival is very high, also showing indirectly what this treatment means to the patients. So it's a life-changing effect. It has some side effects, usually mild. Nausea, headache can occur the days after the implantation in around 20% of patients. And these side effects go along with the release of the drug from the implant. It's in the first days after implantation primarily, and this is really a drug side effect. But these side effects are generally mild, I have to say. There is a new drug coming up, probably for EPP patients, dersimelagon. It's also an alpha-MSH analogon. The interesting about this substance is that it can apply it orally, and the studies are in patients up from 12 years. There is a phase 3 study ongoing at the moment. The recruitment is already closed, and we hope that we will have first results during the next year from this interesting trial. Yeah, what else do we have to consider? We have to consider that we might or that we should supplement vitamin D in patients if they have vitamin D, have too few vitamin D. These patients have mild anemia, so we may think about supplement iron, but we have to be careful because in EPP it can exacerbate EPP and EPP symptoms. It's different in XLP, but just remember iron supplementation needs to be, we need to be careful here. And of course, if it's really a strong liver involvement, we need to think about transplantation even. You may have heard about beta-carotene as a drug in EPP. It's usually not helpful, and there are also reports about other drugs, but there's no real evidence that they are effective. Yeah, so to finalize, these are my take-home messages. EPP is really, has really a typical clinical picture with these immediate and painful phototoxic skin reactions. And it goes along with a very high disease burden. The quality of life of these patients is really strongly affected. The disease basically determines their whole life. EPP is very easy to diagnose. If we suspect it, we just have to do one lab examination and we have the result. EPP can now be effectively treated with the alpha-MSA analog afamelanotide. This is life-changing for many patients. we always have to keep in mind that EPP can be dangerous. We need to monitor the liver function in these patients. And we have one unmet need at the moment. This is treatment of children. There we hope to get a better approach in the future with other drugs, and maybe also afamelanotide will be licensed in the future when they've provided studies in children. This would be great. So this is on EPP. I hope I could provide you good insights, and yeah, I will love to address any questions you're having. Thank you.
Super, thank you, Karsten. Very nice and so important, because it is an iconic clinical picture, and yeah, let's hope that many more patients get diagnosed with this. Yes, thank you for sharing. I see Sheila, Leah, wonderful. We can start our round of discussion, and I want to do this by Anna's comment, who also thanks you for your nice lecture. And she's asking about the price of afamelanotide. Do you know what these implants cost?
Yes, it's a rare disease. They're quite expensive. I can't tell how it's in other countries, but the price usually is between 10 and 15,000 euros per implant. Good. So it's like yearly costs of around 40 to 50,000 euros. Okay. If they are treated with 4 implants, which is usually the case. Of course.
Thank you. Super. Well, I was surprised to see EPP at 1 in 50,000, which reminded me a little bit of hereditary angioedema, and Lesley sharing 1 in 300,000 for solar urticaria. So I'm pretty sure that we're underestimating, or right now we're under-diagnosing both solar urticaria and EPP, and it would be great to get more information on the real prevalence. And of course, you know, if you have these solar urticaria patients, please bring them to the Solutia project. Please bring them to UCARE. And that's my segue to say hello to Sheila. Hi, Sheila. Thanks for joining. And thank you also for bringing your ideas to this network. You have close to 100 participants from all around the world to share your ideas with. Please go ahead.
Brilliant. Firstly, thank you so much for giving me the opportunity to speak to everyone. It's really amazing to be able to speak to an international network like this. So I'll begin with just a kind of a brief introduction of myself. So my name is Sheila McSweeney, and I am currently a clinical research fellow undertaking a PhD in St. John's Institute of Dermatology in London. Clearly from my accent, I'm not from the UK. I'm from a city in Ireland called Cork, and anyone from that city will tell you it's the only place to be from. So I'm very proud of that. But back to solar urticaria. So my entire PhD project is focusing on dissecting the etiopathogenesis of solar urticaria using molecular genetic methods. And we felt that this would be an appropriate approach to this particular disease because there has been some, but not a lot of mechanistic research into solar urticaria since the kind of 1980s. And we thought we have these amazing molecular technologies that are almost hypothesis free. And so we felt we could really crack open solar urticaria in a new way and develop new hypotheses around its sort of pathomechanisms. So we're going about this in several different ways, but basically the first thing we had to do was consider the solar urticaria phenotype and what that tells us about the genetic architecture of solar urticaria. And just not assuming anyone has a genetics background, genetic architecture just refers to the frequency and number of genetic variants that underpin a particular disorder. And it's important to hypothesize regarding the genetic architecture of disorder as it allows you to select an appropriate genetic study design. So from our perspective, solar urticaria does not demonstrate Mendelian segregation, meaning that it's not inherited from parent to child. And it typically develops in adulthood and doesn't affect reproductive fitness. In addition, it has very variable clinical severity and also quite frequent comorbidity with common conditions like asthma, eczema, hay fever. And so we felt that these features collectively tell us that solar urticaria is a complex trait in which probably both rare and common genetic variants, several of them together, interact with environmental factors to produce the disease phenotype. And I won't go into huge details of what we're planning to do, but basically we're hoping to do two types of genetic study, what we call a whole exome sequencing case control association study, and ultimately we're hoping to do a genome-wide association study in solar urticaria. And obviously this is where, you know, fabulous networks and projects like Soluce come in, because to undertake genome-wide association studies, we need large numbers of solar urticaria patients. So we're really excited to be involved with Soluce and also to contribute to it as well. So thank you for your time.
No, thank you. That's wonderful. Great to see your ideas and your energy and your help for Soluce and for our network. And that is not to say, if I understand you correctly, that we shouldn't send in that rare family with 3 family members affected by solar urticaria plus the same number of non-affected members. No, that's an entirely different question that you, I'm sure, will also be very happy and interested to help with. But let's find solar urticaria patients in the Soluce project, and let's convince them that this little bit of blood, I understand it's a dried blood spot card, or how do you want the?
So we can do it either by blood or by saliva collection kit, but actually the saliva collection kit has been really successful in the UK. We do it in clinic, we post it out to patients.
Perfect.
And to be fair, I don't think anyone has actually refused to give us a sample. They're really enthusiastic to be involved. They want to know more about their condition and to get better treatment.
I'm sure our patients will be as well. Give us your spit is probably going to convince them all. Sheila, thank you so much. Please stay on as we have a couple of more questions, and please join our discussion as we move. Great. So I have a couple of questions that came through on the chat function, but also on the Q&A function. The first one goes to you, Lesley. It says, when you say that 25% of patients are difficult to diagnose by provocation testing, do you adapt the provocation like we do in cold urticaria, where maybe you just do it longer, or you try to mimic real world exposure? What's your approach to these 25%? How do we secure that they have solar urticaria?
Well, I mean, I suppose ideally you'd have even more radiation sources, maybe a broadband visible source. But you know, what we do, we sort of optimize it by having the narrowband and the broadband sources and put them outside in sunlight. And
okay.
Sometimes, you know, it may be that they need a whole host of wavelengths
okay.
to activate certain chromophores. So it has to be, you know, real sunlight. So
super. Look, the next question is also to you. What about the influencing factors that could be a problem? And they want to know about hardening. They want to know about, does an antihistamine really make a test become negative, or can you test on an antihistamine? What's your take on this?
Right. Well, if I can, because I saw some really nice comments there, so thank you, including Margarita and Anna Maria. And just to say a little bit more about photo testing and the value of it in diagnosis and treatment. I could probably have talked for an hour, really. So basically, the broadband testing we feel is really important in photodiagnosis because, number one, it confirms the photosensitivity if it's positive. But number two, it shows the morphology. So, for example, if it's solar urticaria, you're not going to give a second challenge. But if nothing much comes out, or just a little, we give challenges on 3 consecutive days with 2 different light sources. And that definitely increases the yield of PLE, PAD, even hydrovacciniformia. I remember somebody in the past saying to me, you can't provoke hydrovacciniformia. Well, why not? Just because the textbooks don't mention it. So we did it on small areas, and you can, in all of the patients, we brought out these volcanic vesicles. Obviously, you don't want to cause scarring, but in these very serious conditions, I think it's important to pinpoint the cause. So And then when it comes on to the monochromator testing, that shows the action spectrum, and it also shows you the thresholds. So we've got the thresholds, you know, defined for all our SU patients. But if you find that the patient is not sensitive to UVB or very short wavelength UVA, and especially if they're skin type 3 or 4, you might try a course of narrowband UVB therapy. You know, you've got to be confident, and even though we might not have seen a reaction on monochromator testing, we will still, when we do that, just uncover one arm and cover the rest of the patient, you know, with the treatment lamps. So it can influence your treatment. Generally, it's not found that phototherapy is very beneficial, especially in the lower skin types. But in Italy, they've had a bit more, you know, a bit more positivity is suggested in skin types 3 and 4. Although I might be confusing that with EPP. I am confusing with EPP, but so it can be tried. Antihistamines. There was a paper by Peter Farr and Brian Diffie a few decades ago, where they phototested people on and off antihistamines, and this was really interesting because the antihistamines protected to some degree against the flare, but to no degree against the erythema. Okay. So that, I think, is an important, you know, sort of directs a little bit of mechanistic thought. But in general, antihistamines have never really been thought to be that effective, although there was a paper in CED recently by Snast et al. Suggesting that it was helpful if you had a particular regime and you pushed it, etc. So we always will try antihistamines, and we'll always get them up to the maximum dose of, you know, 4 times the regular dosage of H1, etc. But we find with the more severe patients, they don't have a huge effect.
I think the flare, thank you so much, Lesley. I think the flare phenomenon is really interesting because, you know, we have this a similar situation, but maybe not so often in the other CINDUs as well. We have, of course, symptomatic dermographism. You scratch and they get a wheal and it reflects erythema. Picture is clear. But when we scratch ourselves, we also get erythema. It's a neurogenic erythema. With the cold, you also have some patients who will get pronounced reddening of the skin, maybe sometimes even with a little bit of itch or burning, but there's never a wheal. I feel that at least also listening to you now more than once, that is something that many patients experience, just this almost immediate hypersensitive reddening flare response of the skin that comes or does not come with a sensation, burning and itch, but doesn't show a real wheal. So I think it will be very important, and I'm looking at Leah, that when we run Solutia, we have your expert advice and Sheila and everyone who wants to contribute to really understand how do we define that patient population. Do we include those who, and I'm making air quotes, only have redness after solar exposure? Or do we say, no, that's not solar urticaria. We require for them to show whealing after solar exposure.
I mean, in practice with phototesting, even with those who only clinically show a flare, we'll always bring out a wheal as well. So it might be a matter of threshold, that flare comes first, people don't stay out any longer.
Very good. Last question, super. Last question goes to Karsten. Karsten, you alluded a little bit to, or maybe it was you, Lesley, I don't know, afamelanotide as a treatment for other solar-induced diseases. Are we on a path to a new treatment for solar urticaria, or what do you think, Karsten?
I'm not sure about the results of afamelanotide in solar urticaria. Maybe Lesley can also say something to it with more expertise, probably because it's in the end it's an unspecific effect, right? I mean, it's It's increasing the natural sun protection. It probably also has other effects, because the sun protection we see in EPP is not only we don't see that the tanning and the reaction to the drug is completely in line. So probably there are also other effects, but in general, I would think maybe, Lesley, do you have a good answer?
Well, we did a trial with afamelanotide in solar urticaria patients, and we solely looked at objective phototesting, which the licensing authorities don't seem to set much store by, unfortunately. But for a disorder that's very dependent on the stimulus, this was really the only, well, the easiest way to give the same challenge before and after. And we found a significant effect even in N=5. I think melanin is certainly part of it. And the nice thing about melanin is it's a neutral density filter. So it protects not only against UVB and UVA, but longer wavelength UVA and melanin. So it's better than sunscreens in that respect. But as you say, it also has, it's likely to have antioxidant, anti-inflammatory effects that need further exploration. So I think there should be a reawakening of interest. At the time, Clinuvel were very keen to set up multi-center trials. I remember going down to Canary Wharf, and I'm not sure that this made any difference, but the people assessing this were 3 German doctors, and they said, urticaria is a trivial matter. It doesn't require this expense being spared on it. And that was it. They, you know, I've never been so disappointed. I did my best, but they just would not listen. So we need to convince people, firstly, how dreadful these disorders are. I mean, I've had solar urticaria patients who are near suicidal. You know, you can't go out, you can't put the bins out, you can't hang the washing out, you can't go out with your children. So we have to, we've got a battle, but with this big, you know, grouping now that Marcus and colleagues have set up, I think we have a real chance of convincing.
Let's do it. Lesley, you have at least 150 women and men at your side to fight that cause. We know how bad it is to have urticaria, and we will fight to bring the best treatment to, as of yet, underdiagnosed and undertreated urticaria patient populations. Look, I can't believe how fast these 90 minutes went. It is unbelievable, really. And I want to thank you all here. Leah, fantastic. Sheila, thank you so much for joining. Lesley, great to have you in this first UCARE webinar. Karsten, thank you so much for your continued support. And thank all of you on your screens for joining. You made this first webinar a success. Don't forget, in 8 weeks, there's the next one. I know the webinar task force is already working on this. Please check out our journal club, our podcast series, All Things Urticaria, our TikTok channel, Let Me Ask My Dad. Well, all of the other things that are ongoing in the network. And if you're interested in contributing, please let us have your ideas, energy, time to make this program even more successful than its start has already been. With that, thank you. Be well, and I'm looking forward to seeing you all soon again.